All right. So chapter 31 talks about management of fertility and infertility. Okay. Now, we do know that um, some people have more luck getting pregnant than others. Okay. And so sometimes as we are talking with people, not everybody wants to have a baby at a certain time. Okay. So when we're talking about contraception and birth control, they're not always the same thing. So for instance, family planning is a couple who have made decisions about, okay, we just got married and we don't want to have any children for at least 2 years. So we are going to take steps like birth control to prevent pregnancy. Does that make sense? We are planning. Now sometimes we know things don't always work out like we think they should, but that is a plan, okay? And then, things change as they go along. Contraceptives and birth control is deliberately trying not to get pregnant, okay? And then contraceptives are those methods that we use to not get pregnant, all right? So that's kind of a little update on that. So here are some considerations when choosing a method of birth control. Again, not everybody is suited for birth control pills. Not everybody is suited for an IUD. So there's different things that we need to discuss with our patients about the advantages and disadvantages of the different methods of contraceptives. Okay, so you can see they're listed here: safety, protection from STIs, how effective are they? Are they acceptable to the couple? Remember, sometimes there are religious and cultural factors that come into play with our people. And so sometimes, like the Roman Catholic Church really only wants you to use the, oh goodness, what's it called? I forgot already. It's like it's the family, oh, now I can't remember what's called. Well, we'll find it. Anyway, there's one that only the Roman Catholic Church accepts only that way of preventing pregnancy, supposedly. Now, a lot of good Catholics don't do that. They use other methods, and that's okay. We're not going to say anything about that to them. So there's things like cost, convenience, how easy is it to get pregnant when you go off of those or stop using those. There's a lot of things that go into deciding what type of contraceptive you want, or the couple wants, rather. So I found this in another book, and I forgot to put my reference on it, but it's in my office. You can come and read it if you want to. It's kind of a nice little acronym to kind of help you keep up with what you're doing with your patients using the acronym BRAIDED. I forgot to put my reference on there. I'm sorry. So the B stands for benefits, R stands for the risks, A stands for the alternatives, I stands for any inquiries or questions your couple may have. D is the decision. It may change their mind. They may have come in with an idea, and then because of your great patient teaching, they're thinking, maybe this other one might work best for us. The explanations about how it's used, what to do if you forget, that kind of stuff, and then what you did, your documentation. And you see here, and this is a very statement we've made before, education of the patient is the cornerstone of nursing care plan and plan interventions. So education is huge, especially in this particular setting with this information. Okay. So let's talk a little bit about teenagers, adolescents, and contraceptives. Now, I don't know how maybe you are aware of this, but people are starting to engage in sexual activity at a younger age. There's kids 10, 12, 11, 12 years old having sex already, which scares me half to death. But anyway, it is happening, okay? And so we have to try to capture that audience, if you will, because they often have misinformation. They have all kinds of strange ideas about when it's safe, when it's not, what you should do, what you shouldn't do. And of course, sometimes they don't have parental consent. Their parents don't know it. So there's a lot of things that go into this adolescent population. And so they often take risk-taking behaviors, because when you're young, don't you kind of have a Superman ideation, like nothing can happen to me, I'm young and I'm strong and I'll be fine, because it's not going to happen to me, but it could happen to you. So oftentimes they go to parties and they have multiple people having sex with them, and that's very, very risky. Okay, so we need to address those things and let them know, hey, you need to be careful. Okay, So, and so sometimes we just need to counsel them, and we need to be comfortable with what we're saying, as far as it's a very touchy subject, so to speak. That was not the right term to use, but uh, it's a very sensitive subject, okay? It's very private, okay? And so a lot of times people don't want to talk about it, but we have to start the conversation with some pretty straightforward questions like, there's a lot of kids your age that are already having sex. Does that include you? Or, something like that. Because if they think other people are doing it, then they think it's okay, but not be the case. So we have to gear our questions and our information to that level. Don't talk down to them, but also remember you're not going to talk about the chemical makeup of the birth control pill. They don't give a hoot. They just want to know what it does and how it works. And so also part of that conversation would be that the younger people are more at risk at acquiring HPV because they're not taking precautions, and a lot of times they don't have the vaccination, and so they're more at risk for HPV, which we know, those of you who are presenting HPV, increases your risk of cervical cancer, right? Who's doing HPV? What group? Is that true? Yeah. Huh? Yes, it is. Okay, good. Then, of course, we have a population called perimenopausal. What does peri mean? Around, okay, around menopause. They're not quite there. They may starting to have some irregular periods, heavier periods, lighter periods. It all is kind of pointing to menopause. Okay, it's not quite there yet. So perimenopausal, as you see here, they can still ovulate and have periods between. They might start showing these signs 35 to 40 years, but most commonly in that period they may have some perimenopausal symptoms. And then thinking that, they're thinking, oh, I'm going to menopause, I don't need to use birth control anymore. And guess what? You're 42 years old and you get surprised. Your other kids are grown and all of a sudden you're having a new baby. It can happen. So we need to counsel them as well about using something. The most common method used by women older than 30 is they get sterilized. Either their tubes tied or ligation, what you call it, or their partner has a vasectomy. Okay, they don't want to, they're through with it, they're done with it, they don't want any more, and so they make that decision. Okay, here's those helpful information slides, paces I told you about. We just went over those. So we're going to go on. Now, this is the different methods of contraception, okay? There's a bunch of them here, right? So there's a lot of choices for people, and sometimes everybody kind of thinks, well, I should just take the pill. Does the pill offer any protection against STIs? No, there's certain barrier methods that if they're really concerned about they have multiple partners. I'm just being real here. They're having lots of partners, and they're thinking the pill is going to keep them from getting pregnant, but it's not going to keep them from getting STIs. So, there's barrier methods that do offer protection from STIs that some couples may prefer, or some individual may prefer. But you see here, sterilization, also known as a tubal ligation, okay? What do we do when we ligate something? We cut it, okay? And there's different methods of tubal ligation. They go in, they cut it, and they burn off the ends so that the ends can't grow back together. Sometimes they just cut the ends and sew them together, and there have been rare occasions, that the ends grew back together and the woman got pregnant. Now that's very rare, but it can happen. It's not 100% foolproof. The only thing that's 100% foolproof is abstinence. That's usually not a very popular method of birth control. I'll just tell you that. You all know that already. Okay. So, and then of course in the male, it's the vasectomy. All right. And believe me, it's easier, believe it or not, fellows, it's easier and less recovery time for you to have a vasectomy than for your girlfriend, your wife, whatever, have a tubal ligation. Okay, it's a little more in depth for the woman. Okay, she has to have general anesthesia. A vasectomy does not. All right, so that's a little different there. Then you've got the hormonal contraceptives. There's implants. There's pills. There's emergency contraceptives. There's the transdermal patches and shots and all kinds of things out there. Okay, so different things are going to work better for some people. Like if a woman's going to have trouble, remember, taking a pill every day, which I do, I have to put my pills out where I can see them or I forget them. That would not be a good way for me to keep from getting pregnant because I would, okay? But if that woman doesn't want to have a baby and she wants contraception, maybe a pill's not for her. Maybe that patch might be for her, or the injections they can get, so that she doesn't have to worry about remembering to take a pill. It just depends on that person and what works best for them and their lifestyle and so forth. Then you've got the intrauterine device, or the IUD, all right? And you've got the barrier methods like spermicides, gels, foams. They're inserted into the vagina and they work better. They work better with maybe a diaphragm, and that. The two together are pretty effective against having pregnancy and STIs. And then you've got the male condom, the female condom. I had a female condom back at where I used to work, but I couldn't find one here. Anybody ever see one? They're quite strange. If you ask me, they're kind of weird looking. And then you've got a vaginal sponge, which is kind of like the spermicides and the gels. You've got the cervical cap, which is a little different than a diaphragm. It's not quite the same. So there's different things for different people, all right? You've got your injectables like Depo-Provera, your patches. They usually have to be changed every 3 times, wear one times 3 weeks and then take a week off, okay? Because that usually is when the period will start. Then you've got implants, all sorts of things that are available for people. All righty, let's see. Emergency contraceptives, I'm just going to mention quickly. They have to be used within 120 hours of unprotected sex. There's different pills. There's actually sometimes a doctor will insert an IUD because the presence of the IUD will prevent the fertilized egg from implanting, and so the baby will not develop. Okay. Then, of course, we've talked about the oral contraceptives, and you see here that there's things here that talk about concerns with oral contraceptives. Let's look at some of these. If they have a history of clots, they can't take oral contraceptives. If they still smoke, they're at risk for that, of course. Some of them that if they have an estrogen-dependent cancer or breast cancer. Now we're going to touch on breast cancer when we talk about chapter 32, but not in depth because you'll get that in Med-Surg 2, I think. Yeah. And anyway, so we'll talk about it, but there is certain cancers that if you give them estrogen, they just grow rapidly. So if they've got something like that or a history of that, they cannot take that because most of the time in the oral contraceptives, one of the ingredients is estrogen. Okay. They have hypertension. Sometimes, they can raise your blood pressure. Also, a benign or malignant liver tumor. Okay, now you say, wow, if someone had a benign liver tumor or a malignant tumor, wouldn't they take that off? Well, they might, but it just depends on the severity, the location, the rate of growth, et cetera, et cetera. But we would not want to take that chance of giving that patient that. And then you have all kinds of other things. You've got the single type, and you've got combined. Any of the above conditions, liver function, suspected pregnancy. If a woman doesn't know for sure if she's pregnant or not, it would not be a good idea for her to take oral contraceptives, because if she's pregnant and she wants to keep the baby, then it's probably going to have a miscarriage with that. So those are some concerns or complications that could arise from using oral contraceptives. And while we're looking at that, I think I have it later on. No. Remember that little acronym I said ACHES? I put that on that same page on my notes with this slide. The A stands for really bad, severe abdominal pain. Really severe, not just a little bellyache. Really like doubling over, hard abdomen kind of stuff. Okay. The C stands for chest pain. Okay, so if you are telling your patient who's been prescribed oral contraceptives, they don't have any of this criteria, they're safe to take it from what we can tell, then we need to teach them, hey, if you experience any of these things, you need to call your provider right away. Okay? If they're having chest pain, I would suggest they come to the ER. All right? Headaches, not just a headache, a blinding, severe, pounding headache that is not like any kind they ever have had before. All right? The E stands for eye problems, blurred vision, photophobia. Well, that could be a migraine. Well, it could be, but wouldn't you want to know for sure? Okay. Excuse me. And then the S stands for severe leg pain, in particular in the calf. Okay, what could that be a sign of? DVT, absolutely. So we don't want to mess around with this. Okay, this is just a little something that you can. I bet a lot of doctors' offices have these pre-printed and give them as part of their discharge teaching with your patients. What was it? Question? Oh, okay. All right. Questions, anybody so far? We doing okay? All right. Yeah. You run the risk. You increase your risk of getting clots. If you smoke and take birth control pills, you are increasing your risk of clots and stroke. Mm-hmm. Absolutely. Good point. Absolutely. Any other comments or questions? That's good. Okay, we're going on. So that's it. The natural family planning, okay? That's the one that the Catholic Church likes. And there's other ones. See here, you got the calendar or rhythm method. You got the standard days method. You got the cervical music. Oh my God. Mucus. Well, anyway, we've had a climax and now we've had music. But anyway, uh, cervical mucus and 2-day method, where the woman actually examines her own vaginal secretions to see the consistency, to see if it's safe to have sex or not have sex. Okay, these kind of methods that we've just been talking about require a great amount of commitment, consistency, and motivation. Okay. Now, if you think about all the things that some of these things require you to do to keep from having a baby, can you see how sometimes these methods fail miserably? Okay? Because, we're all normal people here. We like to do our thing. And so, in the heat of the moment, you might not take time to look at your cervical mucus. I'm just saying. So you need to make sure that you need to tell a couple, hey, this requires consistent use. You have to be very, very motivated to do this, and you have to be committed to it. Now, there are some that are, and I think that's great if that's what works. So there's a lot of different things that we can point out to people to make sure they make an educated, informed decision about what they're doing. And that's what our job is to educate and inform. Okay? We don't have to point one out. If they say, what would you use? What do you say? Right. You say, that's an individual, very personal decision. I cannot advise you. I'm giving you all the information, and they don't have to make a decision that day necessarily. They may have to take it home and, really look at it and spend some time with it and talk to people and whatever. Google things. I don't know. Whatever people do. All right. So it's our job to give the information in an accurate, factual way and then let them go from there. Okay. All righty. And then, of course, there's the abstinence, which works great. And the least reliable, as you see here, methods of contraception is because you're breastfeeding, you're not having periods, you think you can't get pregnant. We already dispelled that myth, didn't we? We said, no. That is possible. And then, of course, there's the coitus interruptus. Do I need to explain that? Mm-hmm. Jonathan's laughing. Yeah, that doesn't work very well. That, even if the man does not ejaculate in the woman, there's still sperm going out. So don't rely on that, all right? I'm being real, people. I know this is kind of a sensitive subject, but we have to make sure we have ourselves, our emotions, our feelings worked out ahead of time before we try to teach our patients. Because if we get giggly, yeah, if we get giggly, we get red-faced, we get uncomfortable, they're going to pick up on that really fast. So the time to do this is before you get to that situation. Prepare yourself. Same thing if you have a patient has been diagnosed with cancer and they don't know, and you're going in with a physician to tell them the bad news. If you walk in and you're a wreck, how are you going to help your patient? Right? So you have to think about these things ahead of time. How will I manage this? And sometimes if stuff happens and you cry with your patient, is that bad? No, don't lose control and have to leave the room and go take a break for 15 minutes. That would not be appropriate. But you know, I've cried with patients. I've cried in the delivery room when we had stillborns. It was very, very sad. It's okay, but you can't fall apart, if that makes any sense. All right. Any questions, concerns, questions about anything we've talked about so far? So be sure and look over those tables and those boxes that I showed you. Those are great sources of information. You might even look at that and then just skim the reading, because lots of times they take all that reading and kind of chunk it into a chart, which makes it easier to get. Okay. Now we're going to switch gears and talk a little bit about infertility and fertility and so forth. So infertility, what does that mean? It just means that you're unable to conceive. Okay. You're unable to conceive. And so sometimes you're not able to conceive, and usually they say if you've been trying to have a baby for a year, then you should start thinking about, and you're not pregnant yet, that you should start thinking about going to somebody and getting everything evaluated. Okay? So that, yeah, it could be a lot of different things. So it's not necessarily in any one thing sometimes. Sometimes it's combination. Sometimes it's one thing. So encourage your patients not to just guess or go by what somebody else has told them or what another person's experienced, because it's very, very individualized. So it's got to be both people, the male and the female. And then sometimes they do things as a couple. Okay, we check the female, we check the male, and then we check them together. So it's a holistic approach, if you will. All right. There's many, many things that go into infertility and why people decide maybe to have the in vitro fertilization, maybe a surrogate mother, or adopt. Okay, and so there's many, many factors that go into their decision as far as you can, like our social, how acceptable is it to that culture or that ethnic group to do these sort of things. Okay, and I said culture, religious values. Some people are just like, if God don't want me to have a kid, then I'm not going to have a kid. Well, I guess that's one way of looking at it. And then sometimes they'll say, we're going to keep praying, we're going to keep trying, and that's fine. We support their beliefs. We may not necessarily believe the way they do, but we support them in their belief. Okay. The difficulty of the treatment. Have you heard stories about people going through infertility procedures? Anybody know anybody that did? Tell us about it, Misty. If you can.
She hasn't really had any, she didn't really have any problems with it. Mm-hmm. She did, she went and it didn't take. Oh. So they had to do it another time, mm-hmm. which is very costly, very mm-hmm. expensive. But the way that it is designed now is you can literally pick the sex of your baby.
Wow.
If you have like multiple eggs, you can pick, they can sex them. And so.
Wow, that's kind of creepy.
She had boys.
How about you?
It was my friends. They went ahead and tried to conceive after me for 7 years. Mm-hmm. It was long. Weren't able to until they did all the F, and it took. And now I have a brother.
Yeah. Yeah.
And then I have an 11-year-old sister who wasn't into.
Oh.
Okay. I did 7 years, couldn't get pregnant, and then surprise, after him, I had my sister.
My cousin that had the little girl, she was born June 6th, and then the next year they, on June 16th, had a little boy by the teeth.
Oh my. That happens sometimes. And so it is costly. It's very costly. And sometimes it doesn't work, and they have to go to a different method. There's different methods of doing that. And so I'm not going to go into all of those because some of them are quite complicated. But if you happen to end up working in a clinic or an area in the hospital that does this, you'll know this stuff like the back of your hand, how they do it. But it's obviously artificial somehow, okay? And it has to be implanted into somebody, a perfect woman with a uterus, obviously. But so it is costly, and it may not work, and the couples may try and try and try and try. And how do you think that does it take a toll on their relationship? Sure it does, because it's stressful. It's very emotional. Let's just say, for argument's sake, that the man has a low sperm count, and they've decided that's the problem. That's why the woman isn't getting pregnant. How do you think the man's going to feel? How would you feel,
Useless.
Jose? How would you feel if you were in a relationship and yeah, not capable, not man enough, maybe? Yeah. What if it was the woman and she had a strange shaped uterus that would not allow a pregnancy? And there are some pictures in your book about strange shaped uteruses that are not compatible with having a baby. Yeah, her fault. I feel defective. Yeah, useless. Yeah, because I was not one of those women who just was craving a child. I never felt that way. I thought if I have a kid, fine. If I don't, okay. It didn't make any difference to me. Some women are just, oh, they've got to have a baby. Their life is not complete, and that's okay. So if they can't, obviously, it's going to be very emotional for them and a stumbling block, maybe in their relationship with that person that they're trying to have a child with. The probability of success, and of course, we talked about how costly it can be. I have a little statistic here. It says about 15% of reproductive age couples it affects them as far as infertility. So that's a pretty good chunk of people right there. It might even be more by now. I'm not sure. So as we get older, we're less likely to be able to, get pregnant right away. Some people do, some people don't, but it's more likely that you're not because as women age, everything kind of starts slowing down, the production of eggs and all that stuff. So it might be a little more difficult as you get older. All righty. So let's talk about factors that contribute to infertility. And I'm on one slide, the man and the female, okay? And I'm not going to read these to you. You can read them on your own, but you can see how there's many factors here that can contribute to the lack of conceiving. And honestly, you say, well, I got pregnant really easy. But often when you think about everything that has to happen in order for a baby to be conceived and get to the womb and be implanted, it's pretty interesting how it all happens. It's almost like a chance sometimes. So it's just how it is. And so we have a lot of things to think about as far as fertility versus infertility. Some women seem to get pregnant easily and some do not. It's just how it happens sometimes. So we talked about, here's your male and your female, low sperm counts, abnormal sperm, et cetera, disorders of ovulation for the woman, on strange shaped cervixes and uteruses. They might be able to do a little something with that, maybe not. It just depends on how extensive it is. So lots of times when they're doing the female fertility, they'll do diagnostic tests like check for ovulation. They will do hormone analysis. They'll do an ultrasound, and most likely they'll do both a transvaginal and a transabdominal to see what's going on in there, to see if there's any, unusual things going on in there. They may have some endometriosis that has left some scarring that they may have to look into, and that might be part of the problem. They may actually do what's called a hysterosalpingography. What the heck is that? When you see the word salpingo, you should think of fallopian tubes. Okay, salpingo means fallopian. So they're going to shoot dye. What they usually do is they shoot dye and see if it goes through the tubes. They'll follow it through the tubes. If there's a blockage from one of the tubes, then they'll know that's part of the problem. So, and remember, anytime you have a dye, you have to know about their allergies and all that stuff. So that follows you. Everything you learned about that is going to go with you. Okay. Pardon me. And they may even have to do a laparoscope. And then on the male, they're going to do sperm analysis. They may do an ultrasound on him. Look at this, scrotum and all that stuff. Okay. So there's different things they can do to help facilitate pregnancy, or especially ovulation. They can give medications to stimulate ovulation. A lot of these medicines that they give these women, one of the bad things that they have to think, I don't know if it's a bad thing, but it's a consideration for sure, multiple births. Okay, not just twins, like more than 3 or 4. That could scare a lot of people. I worked with a nurse who had problems getting pregnant, and she finally had IVF, and she carried the baby. She had twins, and she said, "Well, I'm scared to death. I'm having 2 babies at once." Some people can handle it, some people can't. So that's a consideration people have to think about: is we could have more than 1 baby. Are we prepared for 3 or 4? Okay. And there's all that stuff that goes with that, all those emotions and concerns and finances. And, we got a 1-bedroom apartment. We're going to have 3 babies. This won't work. So those are a lot of things you have to think about. And you are part of that process of educating people. Don't forget your discharge planner and your social worker. Remember, you need a social worker, a discharge planner, and a pharmacist in your pocket all the time. They're in your corner, all right? And respiratory therapists, don't forget them. So there's medicines, there's surgical procedures, egg donations. There's all kinds of things they're doing now, and I had no idea you could pick the sex of your child. This is beginning to sound like something in the future, but anyway. And then you've got all these things, the assisted reproductive technologies, IVF, GIFT. Oh my goodness, there's so many there. All they are is they're just artificially helping the person get pregnant is what they really are. And there's different techniques. There's a little picture of how they do IVF. And of course, lots of times after they do these, the woman has to lay flat for a certain amount of time with her legs up in the stirrups sometimes. And sometimes they let them put you down, but they have to be flat. Because if they stand up, what could happen? Things could fall out. You wouldn't think so, but they can't. So lots of times they had to be there for a while in the procedure room or whatever. And then when they go home, they may have some significant physical activity restrictions as well. And then they have to wait and see if it, quote unquote, took. All right. So outcomes after infertility therapy. Again, if it works or if it doesn't work, there's a lot of psychological issues that go into that. So sometimes if a couple decides to do the in vitro or whatever, lots of times at a clinic that does those sort of things, they already have in place people to talk with them about, counsel with them about, what's coming up, what to do if it doesn't work, what if it does work, what we're going to do, those kind of things. So there's a lot of psychological issues that have to be addressed as well. And then if, let's say it takes, but then a few weeks later, she has a miscarriage. So then there's all that, they had to wait and wait and wait to get it done. Maybe they saved up money for a long time, and then they finally got it done, and they took, and then a few weeks later, she had a miscarriage. So that's a lot of loss, a lot of bereavement that people have to go through as well. Parenthood after infertility therapy, again, having 1 baby is pretty expected, pretty quote unquote normal. Having 2, 3, 4, 5, whatever, is not expected as a general rule. And so they have to be prepared for those sort of things. And of course, as the mother's pregnancy progresses, the more likely she's going to be at risk for preterm labor, premature rupture of membranes, those kind of things. And so she may have to quit working, and then there's a loss of income. So you see all the things that go into it. It's not just a procedure that we do. There's a lot of other things that we factor into it. And then sometimes there's menopause after infertility. Some women really hate it that they no longer have menstrual periods. I don't know anybody in their right mind that would feel that way. But anyway, that's my opinion. But they're like, oh, I can never have a child. Okay, that's what it is. Sometimes they go through, they don't have a child, and then they go into menopause and they're like, I never did produce. They feel bad. So there's psychological things that we have to deal with and help our patients deal with more than us. And it could be happening to us too. So we have to take that into consideration. Here's more info, and I think I shared with you.